15 minutes of question and answer.
Excellent.
Okay, so we've got about 15 minutes for Q&A, and we've got a hand just a little bit down the row, and then we've got a second one a little further forward, and then I see a third one over here in the black. Okay, perfect.
Thank you for such a great talk. So with these relationships in the brain, since you're able to identify people who are at a higher risk for developing chronic pain, are there any studies that you know of or any people who are working on using that subgroup who you have identified these limbic pathways and systems and actually provide an intervention to stop them from going into that maintenance phase to turn it into more of an emotional experience instead of like a nociceptive, painful experience?
We just finished a study like that. So I did not emphasize much in my talk. This circuitry has massive dependence on dopamine. Okay, so and in fact we had animal data that shows that if we give humans dopamine plus NSAIDs, maybe that would stop the transition. And we've been doing this for the last 3 or 4 years, using our model first to identify who is at risk and only treating the ones at risk. We just finished the study, and I can report to you that the results are completely flat. There is nothing in there. Okay, this was a massive undertaking, about 5 years of data collection, and we simply failed. Now, I don't know whether the treatment was not large enough. We were being very conservative. If we did not start early enough, there are many open questions, but we just finished the study based on our model, first predicting the risk factors, categorizing subjects into risky versus non-risky. We have the data and we are still looking to see whether we actually validated our model in this population. I don't know the answer, but yes, we're doing this now in many other studies as well.
Thank you very much. This was a very mind-enlarging talk for me. I'm kind of new to this, and to look at pain as a learning experience is interesting. You mentioned a little while ago about dendrites actually shrinking. I was told years ago, and it might be wrong, that dendrites actually grew in a chronic, it's like CRPS. Could you speak to that a little bit?
I don't know that data.
Okay.
If I would know that data if it existed.
Okay.
So I don't know where that information came from.
It was from a pain doctor many years ago. So
well, pain doctors cannot measure dendrites of neurons.
Okay.
So these are not easy experiments. They're hard to do. That was a person who misread something or another, I suspect.
It was about 20 years ago, so obviously a lot has changed.
Well, 20 years ago, the chances of that experiment being done is 0.
Thank you very much.
We have a gentleman in black over here. And then I've got a person in the back, and then another person a little further forward.
Hi there. I'm still trying to work out how to answer this question, but it goes something like this. So we're looking at this as a neurological vulnerability, right? That we have predictors. And I don't know if it's been studied or if you would just make some guesses on this, but are there some associations with other comorbid conditions? Because you have some data on the anatomy and the functional brain, but for us clinicians, being able to associate it with something in their history would also be helpful.
Yeah, I would love to report to you all those other comorbid parameters. We have very little. So, for example, in these patients, we have obviously monitored their depression and anxiety throughout this whole time period. Of course, they all have higher anxiety or depression as they enter into the study. They all have pain. They're not very happy about having that pain, right? And in the patients where the pain goes away, those parameters essentially go back to normal population. They decrease. The patients who develop chronic pain, their anxiety and depression don't change. They're exactly the same as they started with. And again, it is not getting worse. It is staying at the same level that they started with. Just like their pain is staying at the same level, their pain is not getting worse. It's exactly the same as it was at the time of entry. And anxiety and depression show similar properties. Now, in this population that we have studied was a massive undertaking. We specifically took subjects who had no pain for at least a year before they entered into the study, who only had acute back pain and had no other comorbid pain conditions. Now, that population, I challenge you, how many of them you can see in your clinic. It's a very small number. But the idea was we want to have a single chronic pain condition, and that is not contaminated with all of this chatter about, again, pre-existing pain conditions, predispose them, and all of that. So we have tried to eliminate those parameters.
So then maybe a prospective study would be the next step in terms of...
This is a prospective study.
This is a prospective study. So they...
Sorry, I used longitudinal. I could just as well use prospective. It's the same design. The design is we take a group of subjects and follow them as they change.
But in this case, they were in pain when you collected the data. There was those requirements, as opposed to having no pain to start and then following through time.
Now, ideally, we should do the second experiment. But I'm too old to undertake that experiment, mainly because you have to wait many, many years to be able to collect the data, right? Most people, most of the time, happily don't have pain. So if I sit and wait until you develop pain, I could be waiting for a long time.
We have a question in the back.
Thank you. Thank you, and very interesting information, and thank you for your research. Is there a role for direct non-invasive stimulation of cortical neurons or gene therapy in reducing a chronic pain patient's neurological vulnerability?
You mean something like a TMS kind of procedure, transcranial magnetic stimulation? Is that the question?
Yes, transcranial. In an article I read, 2015, promoting neuroplastic changes, considering the top-down approach as well as the bottom-up approach in cortical neuroplasticity.
Yeah, I mean, obviously, in my prejudice is that should be more effective than the bottom-up approach, right? So top-down manipulation should be much better. I mean, and in that sense, we are now doing many studies, which I did not show you, with placebo. You know, can I just, at least for small periods of time, make a big effect by just giving them sugar pills? And the answer is yes. And it is, again, predictable who will respond and who will not respond to placebo based on their brain properties. So yeah, so these studies are definitely pushing us into the individualized level of pain, at least understanding. I'm not sure about treating. We still are not quite there. I mean, but it's coming. There are lots of targets, and now multiple pharma companies are also excited and they're developing drugs, novel drugs to target these systems. Whether they will work or not, I don't know. But at least we now have a mechanistic approach of where to go. Right?
We have another question from a gentleman in a tan shirt, just a few rows further forward.
My question was related to what she had asked earlier, and looking back at the animal models that you did with the excitatory inhibitory changes with the viral infection.
Yeah.
How did you distinguish between non-pain pain behavior versus just lack of motivation to participate? I'm curious if there was a way to distinguish, and on the larger scheme of it, as she was saying, is this something worthwhile as a route to continue for treatment?
So we actually separate motivation from pain behavior, and in fact, in that manipulation, motivation is not changed at all in these animals. What we are measuring is something very simple. It's the extent of sensitivity of that injured paw to stimuli, and that sensitivity goes away or decreases That's the only thing we see that changes. Nothing else changes in these animals. And the other body responses, their motor abilities, their anxiety levels, all of those, anxiety-like behaviors, for example, we can measure them and they don't change. So it's a very specific, it's a very minor manipulation, but it's giving us a very specific behavioral outcome.
Thank you.
Mm-hmm.
There's another question here on the other side of the aisle.
Hi, thank you. I suppose my question relates to the population. So you followed them over a year, and I wasn't clear whether they had any interventions in that time, any treatment, or whether they just did their own thing. And
good question. Yeah. Let me answer the question. Yes. So my hypothesis when we started the study was that there is no serious interventions out there anyway, so they can go and do whatever they want to do.
So that kind of leads me into that.
Sorry, I'm a basic scientist. I can make these statements.
Yes.
And so we let them do whatever they want to do. Okay, and all we did is track them. And yes, the people who were so in fact 50% of the population did not report as doing anything to treat their pain. They were just living with that pain, and in a sense they were in this concept that, oh, next week my pain is going to go away. And so even 3 years later, there were patients who have had the pain continuously and had not sought for help or treatment. That's number one. And now, if in fact we take the data of the treatments, whatever treatment they were using, and use it in our model, it is a significant parameter by itself. So yes, and the only thing we could show is that early treatment was more effective than later treatment. But as soon as we put our brain parameters in, those treatment effects simply were washed away. So now you can think of that as a good result, in that the treatment is co-varying with some of these brain parameters. But these parameters are stronger, so that in the model that we generate, those parameters disappear.
And I guess I just wondered whether how you would talk to, say, patients who are looking at this and may take a message away that it's a fait accompli, that if I show this brain activation, I am destined to chronic pain. Is there any optimistic words that you might?
No, that's exactly the point. So in a sense, even the positive results with the treatment, even though it doesn't survive the model, it shows these are probabilistic events, right? This is not that in a sense properly controlling this circuitry at that transitional state would give us exactly the kind of window opportunity with which to stop the thing from happening in the ones who are more vulnerable and the ones who are not. So look, if you go back, think of this data from another viewpoint, what we have shown, we don't know exactly how to treat the ones who are vulnerable, but what we can do is not treat the ones who are not vulnerable. So I have cured 50% of the chronic back pain population by saying they don't need any treatment.
Do no harm.
Right?
Yeah. So there is hope.
Yeah.
Thank you.
There was a hand in the very back. Was that an internet question or no? This is a gentleman. Okay. Thank you. Thank you.
I was just wondering if you've done any work or familiar with any work looking at, for example, like the long and short dopamine alleles in relation to this.
Say it again, I'm sorry.
I'm sorry. I was curious if you've done any work or looked at any work where they were looking at genetic variability in terms of this vulnerability, for example, long and short dopamine alleles, that sort of thing.
Yeah, I mean, we don't do much genetics. There's a whole group of pain geneticists working out there. But in my model, if you noticed, there was a gene in there that we had put in, but there was a very small genetic study. The concept, of course, some of these anatomical structural properties must be genetically predetermined. But exactly what genes those are, our whole pain and genetics field remains a real mess, and it still needs to grow up, and we need to, to end up finding reproducible genes and mapping them to the brain. All of that needs to be done. It has not been done.
We had another question right back there. I see you guys up here. I'm not sure if we'll get everybody.
I'll make this quick. So thank you for this talk. What I remember from last year's Pain Summit, that with researchers using rats, that there is a difference in, I guess, how female and male rats do perceive pain. And I noticed in both the Buliki and the Wren articles, they both use male rats in particular. Do you have any, I guess, future research, or have you already looked into how both the female and the male brain, or at least in the rats, interpret the pain?
Well, I mean, in fact, we've gotten some funding from NIH to look at our data specifically as gender differences. At least in these data sets, when we've looked at it, we cannot see anything different. Now, the rat data, you're right, we were using only males. That's just stupid tradition. And we've moved on, and in fact, we now do both equal representation for both genders, kind of thing, even in the rats. But the human data is 50-50 between male and female. So, and in that data set, we don't see anything jumping out. There must be something in there. We're still looking. I want to find where is the sex chronic pain interaction. We have not found it yet.
Thank you.
I hate to say it, but those are all the